Hello everyone and welcome to this new video. Today I won't be alone. I have a guest you're about to meet, Professor Madek, who's going to talk to us about a very specific topic. By the way, this is a good time to remind you that on charles.co we'll be doing more and more videos with guests and collaborations. So if you don't want to miss them, don't forget to subscribe, comment, and keep this channel alive. And the usual reminder, you know that when we have health problems, especially in the field of sexual health, we don't stay alone struggling for months and months if we can't manage. We consult doctors in town or via teleconsultation if that's easier for you. But we don't stay alone isolated. We get informed and we consult if we need to. Without wasting any more time, Professor Madek, hello. First of all, could you introduce yourself? Tell the people watching who don't know you what you do, your background, and your medical specialties.
Hello, thank you, Gilbert, for having me. For this somewhat special show, I'm Dr. Francois Xavier Madec. I'm a trained urologist, but also an andrologist and sexologist. So I deal with all kinds of sexual disorders in men, problems that we're going to talk about today, which are narrowings of the urinary canal, urethral strictures, and my field of activity. It also includes genitourinary reconstruction as a whole, which also includes genital reconstructions for trans people.
So, in fact, it's an activity where there's both consultation and surgery.
Indeed, there's a fairly significant surgical demand because most, or at least a certain number of the medical conditions or cases that I manage will, in many situations, require restorative or reconstructive surgeries.
For those watching, we'll put your name and your activity in the video description. So today we're going to talk about urethral strictures. It's a topic I've never covered on the channel before. If you could first tell us what urethral stricture is, what do we mean by that?
So we have this organ called the urethra, which allows urine to be eliminated from the bladder to the outside. And so on this canal, which is a conduit, there can be narrowings. These narrowings are called urethral strictures. We consider it a narrowing. To give you an idea of the size of the conduit, we speak of narrowing when the diameter of the conduit is less than 5 millimeters in diameter. So that makes a conduit perimeter of less than 1.6 centimeters.
To remind you, the urethra is the canal you see that goes from the bladder to the outside, so through the penis. Where are strictures usually located? Is it more in the penis here or more on the inside?
They're located more in the bulbar portion. On your diagram, we can see there's the muscle in red. Exactly. And so it's in the bulbar portion that these strictures are most frequent. That is to say, in 50% of cases, the stricture is in the bulbar portion. There are other locations, but of course, you should know that the entire urethra can be affected by these narrowings from the bladder neck to the outside, right up to the meatus of the glans.
And by the way, I'm thinking of something I read a long time ago. Is it true that it's one of the oldest diseases in urology for which treatment devices have been found? This, which goes back centuries and centuries?
Yes, indeed, it is one of the oldest diseases. We find instruments, whether in Chinese medicine, Hindu medicine, or even among the Greeks. So, in fact, they are types of probes to pass inside the
Urinary tract. That is when we realize it is one of the oldest diseases. And yet, we do not talk about it much, do we?
quite little. I do not really know why. An American study said that it affected 0.9% of men. And then last year in France, we looked at the number of procedures performed per year in France by urologists. We were still around 28,000.
Not to mention all those who have this problem and may not have gone as far as consulting or having surgery, right?
Plus all those who are under observation or who are on other types of treatments.
And what are the causes? For what reasons can we have the urethral canal, the urinary tract narrowing or becoming somewhat blocked?
Well, that is a bit our fault. That is to say, the main cause for now remains idiopathic in 40% of cases.
Sorry, I'm interrupting you. Idiopathic for us as doctors means that it comes from us.
Exactly.
It is a nice word we invented to say it is my fault, mea culpa. My bad.
Well, idiopathic, we do not really know what the reason is. And then there are iatrogenic causes. So iatrogenic means the care that can be given, care in urology or care in other fields that can be responsible for urethral stricture, notably passing a probe, passing a camera to check for the presence of a tumor or other. And we know that in a small number of cases, this can cause trauma to the urethra and lead to a stricture. And then there are two other pathologies. There are all the traumatic causes, notably trauma from straddle falls. So we saw that the area most often strictured is the bulbar urethra. So in fact, it is under the scrotum.
So if we fall and there is an impact right at that level,
it will press directly and potentially traumatize the bulbar urethra and thus cause strictures. That is well documented. And then the last cause is the inflammatory cause. So we know there is lichen. So it is an inflammatory autoimmune disease that affects the genitals and can therefore also invade the urethra.
How can we know if we have a stricture? What signs will we feel?
These are signs that are very non-specific to stricture. They are signs that are either urinary or sexual. We will mainly have a weak urinary stream. As the urinary stream has trouble coming out, the bladder will tend to contract more regularly and have more frequent urges. Then afterwards, we can also have urinary tract infections that develop because the bladder empties poorly, or even burning sensations because when the stream passes with good power through the stricture, well, it can tear the area a bit.
Yes, it puts pressure on it. Then on the sexual level, you said there are urinary symptoms.
There are some sexual symptoms, notably the narrowing of the canal. There are two types of fluids that pass inside this canal. There is urine and then there is sperm. And so indeed, we can have ejaculatory dysfunctions, ejaculatory dysfunction with various signs. The first is painful ejaculation because we know that the force with which sperm is emitted, well, can tear or damage the area of stenosis, which is a bit lower down. And then when the stenosis is really quite severe, at that point, patients tend to complain more about ejaculation, let's say delayed, meaning that in fact ejaculation occurs, the orgasmic sensation happens, but the sperm isn't emitted and it stagnates a bit at the level of the stenosis.
So the ejaculation itself isn't delayed, but the sperm comes out after having ejaculated, actually.
The term we sometimes use is dribbling.
Ejaculation, yes, because there's no pressure in the fluid that flows out. Yeah, it's elegant. We like that in medicine. Yeah. And if we feel we have this, what do you recommend doing?
First of all, we must confirm the diagnosis, as always in medicine. So that involves a consultation, preferably with a urologist.
Yeah.
Because they'll have the tools for the diagnosis. So yeah, the first diagnostic step is to have the patient urinate into what's called a flow meter, so uroflowmetry, to see the strength of the urinary stream. And we'll be able to observe that the urinary stream is weak with a curve that is flattened.
Sorry to interrupt. There have already been questions on the channel asking what is uroflowmetry. If you could summarize it a bit to explain what this exam is.
So you urinate into a urinal, but we measure the strength of the urinary stream. We measure the flow rate of the urinary stream. So we look at how long it takes you to urinate, the amount you've urinated. And then with these analyses, we can determine an average flow rate. And we can also measure the maximum flow rate reached during urination. With uroflowmetry, we also check if the bladder is emptying correctly. So we do an ultrasound right after urinating, an ultrasound to see if there's any urine stagnating in the bladder. And then the exam that will really allow us to confirm the diagnosis is what's called a cystoscopy. So a cystoscopy involves a camera that we insert inside the urinary tract. And so that allows us to see the area of narrowing.
Okay. And let's imagine that someone has this narrowing, this stenosis, but ultimately doesn't seek advice. They leave it as is. They're bothered, but they leave it in that state. What are the risks of leaving the stenosis?
It's the risk of any long-term obstruction of the urinary tract or urinary pathways. So we know these when we take the example notably of prostate pathologies. It's true that letting things progress like that carries two main risks. The first is a urinary tract infection, and the second risk is the degradation of the bladder muscle. Because by constantly pushing to get the urine out, well, the bladder, which is a muscle, can tear and so create what's called a struggling bladder. Bladders that afterwards, even if we treat the narrowed area function, no longer function correctly.
We don't treat it just for the discomfort it causes the person suffering from it. It's also because there are consequences in the long run that are significant. Are the treatments effective?
What we have to see is that we've relied on certain treatments for a very long time. It was really just dilation or simply dilating. Now, it's quite clear that dilation alone won't actually cure the stenosis. So currently, all the medical societies agree that for a patient with urethral stenosis, we initially suggest treatment by dilation or incision. But patients must be informed that the success rate for this treatment is around, it's between 30 and 60%, depending on the length of the stenosis. And so a certain number of patients will see a recurrence after this type of treatment. And at that point, we consider reconstructive surgery instead. So reconstruction of the urinary tract where we remove the narrowed area and replace that narrowed area using another tissue. And the other tissue we use nowadays is what's called the buccal mucosa. So we take a sample from the inside of the cheek and then position it within the urinary tract. And with this treatment, we have a success rate that's closer to 80 to 90% success.
Oh, yes. Oh, yes. That's really very, very interesting. So it's a bit like, if I may summarize, a pipe is damaged. Either we try to fix it or we replace the damaged part, right?
We make a first attempt at unclogging it. And if that doesn't work, then we'll have to replace the pipe.
So for those watching, it's not about taking medication, it's mechanical, and we have to act mechanically on it, you know? If you have symptoms that suggest this and they persist over time. Obviously, if the flow is weak once or twice every now and then, that's not cause for alarm. But if every time you urinate or every time you ejaculate, there's discomfort, a feeling of blockage, if the semen isn't coming out right or the urine isn't coming out right, simply consult a doctor and check if it's a stenosis, because it will need to be treated then. Well, listen, I was delighted because even I learned things about urethral stenosis, which is indeed a subject that's very rarely discussed. In my opinion, this will interest many people who are watching us right now. In any case, thank you very much for answering the questions and for providing your insight. And if you're up for it, we can make more videos on other topics in the future.
Well, listen, with great pleasure. Gilbert, thank you for the invitation.
Thank you. Thank you for listening to us until the end. If you want to see more information on all these sexual topics and so on, you know that on the channel, all the videos are available. Thanks again, Professor Maddock. See you all very soon. Until then, take good care of yourselves.